Dr. Joshua, welcome.
Hello, sir. How are you?
Fine, fine, fine. So happy to see you. Finally, we are meeting.
Already a grand success, I believe. These 3 days must be a marathon, but it's a moment, I
It's a
tell you.
marathon. And for the audience, let me tell you, this is a very, very special session. Very special session. While we had finalized everything, Dr. Joshua suddenly pinged me and told me that he wants to enter this session for a special purpose. And we just could not refuse. And we extended the session for Dr. Joshua specifically because this is going to be on low carb diet study, something which India wants. And I think it is the first study, Dr. Joshua.
Yeah, as far as I know.
Okay, and that too, this is coming from ICMR, Indian Council of Medical Research. Now, let me introduce Dr. Joshua. So, he is a physician scientist at the ICMR, Indian Council of Medical Research, National Institute of Epidemiology, NIE, with training and experience globally in medicine and public health. Dr. Joshua focuses on studying and improving diabetes and cardiometabolic health in the primary care setting. Very, very important. He is also the principal investigator of the study entitled Effectiveness of Low Carbohydrate Diet to Standard Diet in Individuals with Diabetes mellitus, and that it's a cluster randomized trial. Very, very interesting, Dr. Joshua. So
Yeah,
we are so excited to hear, though we have only exactly half an hour, but let us try to compress and get the some of the good questions, answers out of this. So I'll please tell us about ICMR and National Institute of Epidemiology in a very short, compressed manner.
okay. So, Indian Council of Research, for short, ICMR, is one of the oldest and also the largest medical research organization in the world. And the mandate is to do biomedical research in the public health system, also in the partnership with private sector, and to generate evidence. It's basically for the betterment of the society. And ICMR has 27 research institutes and National Institute of Epidemiology, which is based in Chennai. It's one amongst them. And we conduct a lot of epidemiological studies. We do a lot of outbreak investigations. We do health system research, and also we build capacity, public health research capacity within the country. Or basically, our mandate is also to do betterment, research betterment of the society.
Anup, and you have to connect.
Now,
Right.
welcome, doctor. Can you hear me?
Yes,
Yeah, yeah,
yes,
yeah.
loud
Yeah.
and clear.
So the next question would be, it's very interesting that ICMR is conducting this study. And obviously, since we have been here in low carb field for almost 9 years now. So what initiated you or what interested you to initiate this study of low carb?
Yeah, I'll answer this question in two parts. One is personally and professionally. One is it all started with an anecdotal experience with my mother. She's a diabetic patient with who was on 4 different drugs and on insulin, and she started to gain weight because of insulin. And once the weight goes up, you have to titrate it according to the weight. So we have to increase the insulin dose. It went up to 50 units, and when you look at the blood sugars, it was never under control. So I happened to go through the literature of low carbohydrate nutrition, and I said, why don't we try it? And it all started there. And before that, I went through the diet doctor course. I know back then I was not aware of D Life. I know D Life has some robust course. I need to check it out. So I did that course, and we started the journey together. So within a month's time, she was off of insulin, and she's 67 years, going strong with just on metformin. Her sugars are well within the control. That is the anecdotal experience, I would say. Professional thing is, I the evidence around metformin or any other drug. There's a lot of robust evidence, lot of large, well conducted, well designed trials across the globe, including India. We have been a participating centers. When it comes to lifestyle modification, say for example, you want to say promote quitting smoking in an individual. You come after 6 months and ask the person, you will say, I've stopped quitting. This is all self-reported to please us. This is called social desirability bias, we would say. And when you look at the marker, let's say nicotine or the blood markers, it is not in alignment with what they said. So the lifestyle modification gets shut down in the scientific world. So what I thought, why don't we do a robust study, which a well conducted study, so that we can generate evidence and have some implication on the policy practice. That's why we are all here, on a Sunday night.
So good. In fact, before you, we had Dr. Somalram Venkatesh, cardiologist from Bangalore. So he was also telling that there has to be something on the policy changes. And we are so happy to see that you as a doctor, you are personally benefited in your family with low carb, and this study is coming. Now, what I'm requesting you, Dr. Joshua, is let us now talk on the study. What is it? What is the study design? How it will be done? If you want to share slides, we can do.
Okay.
You have slides, or you can talk. You can just talk.
I think we'll just talk just to
fine.
keep up with the flow,
Yeah.
given the time. So this is cluster randomized control trial. Already have mentioned about it. So this has been planned in urban primary health centers of Greater Chennai.
So before you go proceed, what is cluster randomized trial?
So cluster randomized trial, see, we are all offering this some kind of dietary advice. So we cannot randomize individuals. What we do is randomize, say, for example, there are 100 primary health centers in Chennai. Since this study is planned in Greater Chennai Corporation. So 50 will be following the low carbohydrate diet advice, and 50 will be following the standard diet. So clusters, the units are here. It can be schools or it can be primary health centers. Our case is urban primary health centers in Greater Chennai Corporation. So let me go through the study. So the study is planned in Greater Chennai Corporation, and the intervention is all about offering low carbohydrate diet, and also we are giving them opportunity to wear a continuous glucose monitoring. Please mind that this is in the public primary health system in India, where we are giving the patients with diabetes continuous glucose monitoring. So that is, and if you ask about what is the lower carbohydrate diet number of grams, because your area of interest, and I know both of you have done a large work on this. So here I went through the literature and thought this is feasible, and we stuck with 100 grams of sugar per day. And you also need to note that these people are again from the public health system. They'll be getting some raw materials or food from the public distribution system. So some may use millets, and unfortunately, millets are not widely available within the public distribution system. Although India has proposed to the United Nations that this year is going to be the International Year of Millets, it's not widely available. So the two intervention we are dealing here is offering a low carbohydrate dietary intervention, and within the subset of the population, these population are all individuals with type 2 diabetes. We will be offering them a continuous glucose monitoring and see what is the diabetic friendly foods, etc.
Fine. So what can you tell about a little more about the study other than this? How long it is? How long is the study?
The study is planned in a duration of 1 year. So the follow-up duration is going to be 1 year. From baseline to 1 year, we're going to see the blood sugars, and we are going to see especially the HbA1c. You might know that HbA1c, glycated hemoglobin, is not available within the program, National Program for Non-Communicable Disease, for short NP&CD, because on the other hand, the iron deficiency anemia, which is the most common nutrition deficiency in the country, which is iron deficiency, is there in according to National Family Health Survey 5. In women between 15 to 49, the anemia is almost 55%. If there is iron deficiency anemia, as their A1C will be slightly higher, it will be inflated. You will not know the exact value. So, but first of its kind, we want to generate robust evidence. We are excited to include HbA1c as a marker for seeing sugar control. And other thing, we want to generate evidence around what are the diabetic friendly foods. We're going to put them, monitor them at the real time, and see what are the what are the diabetic friendly foods. Also, we want to see what is the quality of life. No, we always have a criticism. These people are missing a lot if they miss carbs. So, what is the quality of life from the baseline till the end line, which is 12 months? And also, we want to do some process evaluations, capturing what are the challenges and barriers. Also, some may do it in a very, very innovative way. What are the possible solutions to follow it on a longer term? So, we are going to get perspectives of the individuals with type 2 diabetes and also from the healthcare providers, also from the family members. They are the anchoring support. If without their support, this cannot be done at the household level.
So this CGM is going to work only for 2 weeks.
Yes.
So what is the objective or the purpose of CGM? What is it, pre or post or during? How is it?
Very good. It's a fantastic question. Actually, CGM is going to be in the initial days. So
Okay.
we are going to say, are you ready? So we will offer all this, in a nutshell. It will not go on a big mode, but we will make it on a 60 minutes compressed package. Basically, my area of interest is patient education through mobile health technology, that is by sending SMS or WhatsApp, and also putting them in groups by giving counseling, because we don't have the resources, especially in the public health system, to do a one-on-one counseling. So I think the strategy should be both. Combination of both should be the way forward. And CGM is going to handle them and see, you are going to visually, they're going to give they will appreciate the decrease in carbohydrate, and they will appreciate the time and range, all those 70% cutoff, and see how many people are achieving and what made them to achieve, and generate evidence of saying these are the list of food items which are diabetic friendly, especially from South India. I think it will go on across the country.
So this CGM you are going to use before. After, are you going to use one more time?
No, this is funded by the government, so we always have resource constraint. So I'm happy that we got it. I will never complain. At least we got this now.
So you will be baselining the HbA1c initially and then later.
Yeah, we are going to do it at 5 different time points: 0, 3, 6, 9, and 12 in both the groups. In the people who are following the lower carbohydrate approach, and also in the people who are following the standard diet. And meanwhile, this subset will have an opportunity to wear the CGM.
Fine. So how are you going to really ensure that they take low carbohydrate food? What are the food which are included and excluded?
There is a list of it's all common food items. For example, we're going to encourage them to say avoid white rice and white sugars and all this white stuff. And millets is going to be the push we're going to do. Uh, the 100 grams thing is going to be a challenge for them. Basically, it's a kind of a plate method. 50% of the plate is going to be vegetables, all above ground vegetables. We're going to cut down the potatoes, we're going to cut down the yams and other things. And the other 25% is going to be proteins. So, which is going to be all this dal and paneer or mushroom, which many cannot afford. That is going to be a big challenge, which I'm going to foresee. It's fine. Let's understand what is doable, what is not doable, at least within the public health system. Other 25% is going to be carbohydrates. That's carbohydrates can come from millets and other things, and protein again can come from chicken, poultry, eggs, and so on. So basically, this is the proportion where it's going to be very simple, and we cannot give them a lot of hand holding. It's going to be one-on-one session, infographics, and check them whether they can follow it. I think a lot of wisdom will come out of this study. That's what I hope.
So is there any particular millets you have included, excluded?
This is the finger millet. If you want to go, if you want me to ask, tell me. Finger millet is, it has a higher glycemic index, when you compare to other 8 types of millets. So finger millet is not encouraged in this particular study.
Right.
Otherwise, it's all other millets are most welcome. It's fine. And also the kodu millet is again it's the closest sibling to finger millet. So that can be taken a put on the back seat.
That's right. I think finger millet is commonly known as ragi or nachni.
Yeah, ragi here.
It is as good or as bad as rice or wheat. It closely crosses around 70%. And I think the other millet might be around 10-15% less.
For a person like me who loves biryani, they can switch to millet biryani. They can even filter and make it in a Hyderabadi style. And it's fine. They can do it in a steady mode. So these are all practical tips, not only for the study participant, also for the general public. There is, at the same time, you can enjoy the real food and keep your sugars under control.
Another key question is, how will you ensure that they follow the plate method?
We are going to have a dietary recall. So the challenge is the subset of CGM patients. We're going to monitor do the continuous glucose monitoring and see whether they are able to follow. If there are glucose excursions, say for example, yesterday 9 o'clock, our study team found that one has 437. What happened? I went to a wedding. I had a big biryani, mutton biryani, whatever it is. So we have to ensure this is what, in order to save that 3 lakhs of dialysis. You want to go do it every thrice in a week, and make others in your family in an uncomfortable situation. If you can follow this, you can prevent all those heart attacks, strokes, and dialysis and amputations and whatnot. So this is going to be the monitoring is going to be dietary recall. We're going to ask them, note it on a diary. So there's going to be, they have to log it, and we're going to review it with them in the initial 2 weeks where CGMS they wear it, and we're going to handle them in the initial week so that it will go on for a year. That is the idea behind the study.
So what is the inclusion or exclusion criteria?
So the inclusion criteria is anyone with type 2 diabetes who has a A1C at the baseline of more than 7%.
Okay.
And the exclusion criteria is the people who are pregnant and people who are terminally ill and mentally challenged are not part of the study. Others are included. So,
Anup, you have any question?
Yeah, before I come to the next question, are these clusters also having, segregation into vegetarian, non-vegetarian? Because you mentioned protein can come from eggs, chicken.
yeah,
You did not mention any vegetarian source.
I assume so. There may be people who are vegetarian. We did not factor into the sample size or the recruitment strategy because not many might be vegetarian, especially in this part of where the study is planned. Uh, if it is there, the strategy is going to be the vegetarian sources. We all know that is going to be the advice we are going to offer.
Okay, now objectives of the study, I think we can guess. You to convert that anecdotal experience into some sort of hard data. Now, let's say, or I would say it would be successful if you're sticking to 100 grams carb. Now, what happens next? The usual procedure is what we have found is we want a bigger study that takes 10 years. We want still bigger study that takes 20 years, and there's no government policy change.
Yeah.
What is the exact objective of this study?
So objective is basically to generate evidence. So see, when I started, I said there are not many primary studies. We all know here, that's why we are here, that there are very good systematic review and meta-analysis from the globe saying that low-carb nutrition or intermittent fasting and bowl works. But we don't have many primary studies, not many, not even a few primary studies, especially in India, well conducted studies. So this is one of its kind, and we'll find out whether it's working or not. The feasibility part will be captured, list of food items will be captured, and also the quality of life will be captured. Other variables, including fasting insulin, serum creatinine, other things are also factored in. But I think any policy practice, it took 40 years for tobacco and alcohol to for the policy change. So the moment is started now. So I think we are on progress. I don't want that 40 years now. That's why we are all into this business. So we want it to happen as soon as possible. So a moment always takes a lot of time. So our business is to educate the patient so that it starts as a movement, and then it will make it, it will happen as a policy practice change. Then, it all will follow.
Yeah, personally, I see that this is the beginning.
Yes.
At least we have some data. Now, if the baseline is above 7, and if they reduce by even, let us say, from 7 to 6.5, it's a big win.
It's a big win when you translate to the public health.
Yeah.
Yes.
A 0.5 or a 0.3% in HbA1c has a huge public health implications. May sound it, people will sound it's 0.3, 0.6 I know, just a 0.3 when it comes to sugar, or just a 5 millimeter or 2 millimeter of mercury can save, I don't know how many lives in terms of stroke or heart attack is a different discussion in itself.
And I see this as it's a start. This study will have a base planning. It may be criticized later on. People may say it is not truly low carb, but I see that even if you reduce carbohydrate by 10-15%, and if it yields results, it shows a positivity, and we can have more extensive, proper low carb diet as per the definition. Anup,
Yeah.
what you say?
Yeah, and also if we can demonstrate within the public health system, anyone else can do. That is a message.
So, what are the challenges you are faced in getting this through?
Yeah, the first, I would say the challenge is, I already mentioned, no primary studies.
Hmm.
Not many primary studies. When we proposed this study within the world, within our world, the first question was sustainability. So how are you going to ask them? You are asking the same question where the higher people at the committees were asking the same questions. How would you ensure these people will be following this diet? We all want to, so that we have a better India with metabolic health. So, but the main thing is not primary in not lot of studies are there when it comes to primary studies within India. So that's a big challenge we have. Other one is sustainability. So how are we going to take it forward, especially when we want to offer within the public health system? Can we make it follow this kind of low carb? That's why I always say lower carbohydrate diet. Even if you can decrease a bit of HbA1c, the expenditure on this dialysis and stents by the government can be saved. The budget on these stents and dialysis can be saved. Huge cost can be saved.
That's really good, and we really support this. And what I wanted to ask another is, what is the way forward in nutrition research?
Yeah, the way forward is, I've already mentioned, see, the way forward is going to be patient education in terms of nutritional labeling. Uh, how can you make the general population to read what is the recommended levels? Sometimes the whatever it is mentioned is not really in line. Whatever, it might not be the true case. So we have to educate the mass. So this is one of its kind. I really appreciate you both for taking this up. And we have to educate the mass that this is wrong. And stick to the real food. Stick to the real food and go ahead. So nothing else. We are not promoting anything. Stick to the real food.
What is the government's inclination? Can we have some policy change, especially surrounding sugar? Because we had a very interesting session early in the day, where a guest from Pakistan was telling the sugar consumption is very high for the matter. So, what is our policy change? Is there anything against sugar, the way it is being consumed in India?
I think a lot of work is done on the nutritional labeling front. FSSAI is doing a lot of thing. So we have to enforce that this is there, so that the public will know and they will be educated this is bad. And what is real food is? Real food is basically which is uh, low in sugar and high in fiber. What is the opposite we are tackling is the processed food or the ultra processed food, which has high in sugar. High in sugar is basically to increase the palatability, and low in fiber to increase the shelf life. The government, if they can regulate, the iron rule of public health is, if they can keep things in check, if they can keep the access minimum, the consumption will be decreased. Banning will not work. Rather, what they should do is tax it up so that the accessibility is reduced, so that consumption is reduced. Therefore, the health outcomes will be better as a country.
I think we know that you cannot ban sugar, but the only thing we can do is to make the public aware.
Yeah. Yeah, basically it all boils down to whatever you're saying, it has to reach to the grassroots
Masses.
people, and we have to educate the masses so that there is a felt need and it will start as a movement. Then only it will start as a policy practice, how it started for tobacco and alcohol. So it takes a while. It took 40 years for the tobacco, and I hope it should not take us 40 years. The policy practice change should be sooner. This is what I also hope.
Anup, you want to ask any question?
Yeah, if results are favorable, which it will be, do you foresee any, big pushback from the big food companies? Because they fund elections, that. Many fund elections, many do, they essentially control the policy, essentially.
Yeah.
Do you foresee any, challenge from that segment of the market?
Definitely there will be there, but we are all independent central research agency. Our thing is not promoting any particular food packet. We are just going to say stick to the real food. Just low in sugar. Basically, the nature is low in sugar and high in fiber, which is to protect the liver. Low in sugar will protect the liver, and high in fiber is to feed the gut. So the bacteria will be happy and we'll be happy. Better cognition, better mood, and better productivity for the country as a whole. So I know we all know this. ICMR India Diet study says that the prevalence of dyslipidemia is 82%, and prevalence of non-alcoholic fatty liver is 40%. So, and if you look at the children, it's 35%. Children are walking on the streets, playing on the streets with non-alcoholic fatty liver disease. And it has to be a felt need. This is an epidemic. Diabetes is an epidemic. Metabolic disease is an epidemic. And non-communicable disease is an epidemic. You have to equate. For example, if I want to, if you permit me to give I know time is running. I'll quickly summarize. TB. Right now, we have 10 lakh people with TB, and 45,000 people are dying in a year. When it comes to diabetes, there are 10 crore people living with diabetes, and 10 lakh are dying. And same goes with hypertension. 19 crore are living, and you have to multiply with 2. So 20 lakh people are dying. So there has to be a felt need in saying that this requires state-specific interventions and decentralized solutions so that we can take it up to the masses. And now only if you educate the masses, only if you do the patient education, will start as a movement. Therefore, policy practice will be followed. Followed by.
I think personally, I think that with the same ICMR study, which was released in June in Lancet, itself showed the huge amount of diabetes epidemic we are facing.
Yes. And there is no urban-rural divide at all. There is no, we always think urban has more thing, except for pre-diabetes. It was all equal. The 11% were diabetes and 15% were pre-diabetes. And you have to note that 10% of the pre-diabetes will be turning to diabetes every year. That is 1.5% adding to the group. So it's all an epidemic. So we need to do something. If you want me to summarize, I would give my key message to our audience.
Please give. We have enough time. Don't worry. Take your time.
Yeah. So I would say there are 4 pillars of metabolic health. As we all know, the 4 lifestyle risk factors, which is physical activity, diet, smoking, and alcohol. I would say 4. I assume that the smoking is not there and alcohol is not there. Let's assume it's not there. The 4 pillars of metabolic health are: one is diet and physical activity, stress, and sleep. Let's focus, and these are all like 4 legs of a stool. If one leg of a stool is gone, the stool is gone. We cannot use it. So we have to strengthen each other so that the stool is strong, so that we can use it efficiently. So each stool can be, each leg of a stool can be, we can talk on for us. But to put it in a less than a minute way, first we can start with diet. We have to worry about the quality. We should not worry about the quantity. Once if you focus on the quantity will be taken care of. That is one. First is diet. Second one is physical activity, and it should be sustainable when it comes to diet. If I ask you, I'm eating this type of diet. When I ask you the same question after 20 years, it should be made in a better way. I should not say, no, I've changed. After 6 months, I was not able to know I was working. No, that should not be the case. After 20 years, it should be consistent. It should be sustainable. Second thing is physical activity. When you do physical activity, for example, small things, you don't have to go to gym and things like that. Start with a plank or a push-ups, which is sustainable. You can add elements. Third thing is stress management. That is that itself a topic of discussion in itself. And fourth one is sleep at least for 6 to 8 hours. So these are the 4 pillars I would say: diet, physical activity, stress, and sleep. If you can tackle, let's since it's metabolic health and low carbohydrate conference, I would say if you can focus on the low carbohydrate, just the real food, sticking to the real food, that is an expense we can all save, than rather than going to a dialysis, which is 3 lakh per year, and it's thrice in a week, and the productivity is gone for our family members and for all of us, and it's all gone waste. forget this transplantation. Even after transplantation, it's going to be 12 lakh per year, the average cost. So just focusing on simple things consistently, it is going to be a big return for investment, so that our country as a whole can have a better metabolic health. This is all we hope for.
Anup, you want to say anything?
Yeah, that's all. Thank you. Thank you.
Yeah.
See,
Yeah, thank you.
personally, I see that Dr. Joshua, what is happening is very, very important and nice in this Indian context. And whatever may be the carbohydrate you have planned, what will actually happen, we don't know. But even if there is some reduction, it is going to be big win. And probably this is going to set a trend for future better studies to come. What is important is this is coming from ICMR.
Yeah.
So
And this is funded by Department of Health Research and
Yeah.
Ministry of Health. So that's a big win for us.
it's a big win, and no one can actually question such a study. Actually, if you show up good production, it is going to have a very stamp of authentication. It is not something which is funded by a private agency so that it will have some other hidden thing. No, and there is no biasness also in the case you have kept vegetarian or non-vegetarian, whatever they can do.
Yes.
So I think it's a very important step. And what Dr. Joshua, I want to tell you is like, see, we from D-Life, we are there to support. So we are there to support wholeheartedly for this study. So please tell us, me and Anup, we are here, and we can, when whatever way possible, we can always help voluntarily.
Sure. I'll be happy to collaborate, and I think we should take this forward. And as a team, I know there's a big cohort. You're all following it up. What I would encourage you to just let's generate evidence around it, like how Dr. Anwin has a cohort of he has gone through my proposal, or he has gone through my chapter which I've written. I've used an infographic. He said it's not copyrighted. Don't go ahead and use it. So that's how we should collaborate and generate more evidence from our country like us, so that policy practice change will then only will happen. Otherwise, we can talk and talk, but the policy and practice changes, it's going to be a long way then.
And we are also so happy that a man from government himself is convinced on low-carb, which is very, very, very critical, and it's a big step. So we are so open to whatever voluntarily we will do, whatever help. Anup will also give you access to our D-Life community. You can come and see whatever all those dishes. Nevertheless, those dishes may not be useful in your study, but it can give you a lot of other ideas also, and possibly it can be helpful. So please reach out to us for whatever help we can contribute in some way to this study. Thank you.
Great. Thank you for opening doors. We'll definitely. I look forward to collaborate, and thank you for the kind partnership.
Yeah, and we are the largest and oldest community, and the kind of knowledge we have is you are less likely to find anywhere. So
I think we need to develop some kind of short videos for the public, as a compressed video, as a group, so that the message is sent across. We can do it as an interest of the public.
We can do that, and we have Anjali here among us, who is from Chennai. She's very happy, and she can make some videos in Tamil also.
Sure. Be happy to collaborate with all of you.
Since it is happening in Chennai, so Anjali is a nice speaker. She's a good she articulates very well. So you can help us. We'll help you make those small videos, and it will really get through. I think we can do that.
Excellent. Thanks.
Thank you, Dr. Joshua. Thank you for coming in this session and sharing your knowledge with us.
And it's a privilege for me. Thank you for this wonderful opportunity. Thank you so much.
And so we wish full success. The entire army of D-Life is wishing you full success for this study. Thank you.
Thank you, Anup. Thank you, Shashi.